as you can see. All right, so we talked a lot about opioids and all the different types, and just to talk a little bit about some other topics related to what we can use opioids for and some other kind of pain-related topics and some reversal agents as well, just to get everything within the same category. So one problem that you can run into treating pain is something called opioid-induced hyperalgesia, which is a increase in pain sensitivity following exposure to opioids. And usually people have to be on opioids for quite a while and at pretty high doses. So most of the time this is going to apply to chronic pain patients. So if you work in oncology or other long-term pain management programs, this is something you might have to see. Otherwise, it's pretty rare if you're just treating people for acute pain or short-term courses of pain management. It's really well documented in animals, but the human evidence is variable. It's decent, but we don't really fully understand why exactly it happens. What we do see sometimes is during withdrawal in opioid addicts, it might occur as well, where they might get this just hyper pain sensitivity response. What they've done to treat it is a couple things. I'll skip to the bottom one, which talks about brief high doses of fentanyl and remifentanil. So high doses of remifentanil and fentanyl would be kind of the exception to the rule when it comes to acute pain management or acute pain treatment, which might end up putting people into a sort of increased pain opioid requirement situation. Now, it's kind of rare, and we still use these medications like water in surgical areas because they're effective sedatives and they're effective pain management. It's not like we stop using them, but it might be something you do see. Although, for the most part, you're going to see it in the chronic pain management. For the most part, what we do, because if you give somebody, you can't really treat their pain, so this person's in a lot of pain, all of a sudden you've hit this weird phenomenon where the person ends up going into this drastic hypersensitivity situation. We can use a drug called ketamine. We talk about ketamine here and there. It's kind of a weird drug that has a lot of interesting roles in medicine. It's getting more and more popular, and I think it's one of those drugs that it's been around for a while, and actually you guys might recognize it as a drug of abuse. But it's a what's called an NMDA receptor antagonist, and NMDA receptors have to do with the way your brain and your sensory nervous system communicates. So if you inhibit that system, you create sort of a dissociative complex, and you can use that in some cases to prevent pain. They also use it as a sedative. It's really popular, like for sedating kids for really short procedures. It's really fast onset and offset, works really well with kids. Some of our other sedatives don't work as great with kids. They move around on them. Ketamine tends to keep them a little more still. So there's a lot of different ways we can use ketamine, but this is just one thing. And the reason why I want to just mention ketamine is because I have seen this where we've had people come into our emergency department where they're on, like, I think the biggest examples I've seen are end-of-life care, hospice care patients, or really uncontrolled oncology-related pain. And we've been pumping them full of fentanyl and nothing's happening. And when you get to a lot of fentanyl and nothing's happening, you can only give so much fentanyl before you're like, okay, let's call this quits, because fentanyl is so potent. So we've tried ketamine in those patients, and it actually tends to work quite well. And we're seeing ketamine used here and there for various other procedures, for things like post-spinal surgery. Sometimes they're using more ketamine, and it just is another pain strategy that's non-opioid related. And in pain management, that's gold. You want something effective that's non-opioid, you're going to use it if you can, or at least try to. So ketamine's just kind of an up and cover. So if you do anything that's like post-procedural care, spinal surgery, chronic pain, you're probably going to get pretty familiar with ketamine as a drug. Okay, so hang on, I gotta get this. There we go. So naloxone, moving away from mu agonists and into antagonists. So these are things we can use to reverse opioids. So naloxone, or Narcan, is something probably a lot of people have heard of. It's really popular in the news right now with the idea of giving it to people to use as a kit, for family members to use, or for people to use on themselves if they happen to overdose, or use on a friend who happens to overdose. And there are actually pretty interesting studies that show that this program is pretty successful at keeping drug abusers out of the hospital. So that's pretty much what we're going to do if somebody comes into the hospital and they've overdosed, whether they're a drug abuser of heroin IV or whether they take a lot of oral oxycodone. It doesn't really matter. They're still at risk for this. So what does it do? It's a pure antagonist, which is kind of nice because it doesn't really do anything other than knock things off the mu receptors. So if you gave this to somebody, like assuming none of us in the room are on opioids right now, if we all took a dose of naloxone, none of us would really notice anything other than the fact that you just jabbed me in the arm with an IM injection or gave me an IV. Naloxone is not orally available, so you have to use some sort of other route to administer it. So onset's in minutes, it works really quickly. Its half-life isn't all that long, which is important to know because a lot of our opioids that people use last longer than that. For example, morphine's half-life is about 4 hours, which heroin gets metabolized into morphine in the body, which is its more long-term acting metabolite. So the onset of naloxone, if somebody overdosed on a big dose of heroin, it's going to work to reverse it in the short term, but that's only going to buy you so much time until that heroin kicks back in once the naloxone gets metabolized. So the kits as an outpatient, they do buy people time to get into an emergency department if they can, but there's a lot of debate over does one dose of naloxone that we're dispensing people really buy them, all that much. And we can give really heavy doses of this for overdoses in some situations. So there's a lot of debate on what exactly is the right product to use. Some of the kits, some companies have capitalized on this and made kind of an expensive kit that's really convenient, sort of just an injection that you twist together. We dispense at our hospital these little vials of naloxone and a syringe, a couple syringes in there. And my question about that was, are we giving clean syringes to people who possibly are drug abusers? Are they going to actually have a clean syringe when they need one? That's a great question. Hopefully they save one. But anyway, it's a much cheaper solution than some of the commercially available ones. So that's why we went with that route. And also what you can do is if you have somebody who's really ingested a lot, so let's say somebody overdosed on their OxyContin, maybe they weren't even, maybe it's accidental, who knows, but that could take a while to get out of someone's system. And if they're chronic, if you're giving them bumps of naloxone, it's just not doing enough, you can give a continuous infusion to suppress those receptors over a longer period of time. We do that for a lot of our more serious heroin overdoses when they come in and it's just not responding well to the first dose. All right.
How do you know if they're responding well? Do you just watch like their respirations, and if they go
Yep, exactly. Yeah, response is based on respiratory rate and mental status. So most people are really out of it because they're going to be pretty sedated. So are they coming back? And if it works, if it's an opioid, it will work and it will be very quick. And you'll see people kind of come out of it very abruptly sometimes. So we try and be as gentle as we can, but sometimes if they're dying, you don't really care about that. So. Naltrexone is another pure antagonist. It's got a little bit of a different role in therapy. It's long acting, so there's a couple different ways we can use this. It does work orally, and it's got about a 72-hour duration. So for opioid dependence, they'll prescribe this as an oral medication. Of course, that requires the person to be compliant with it and actually take it. There's another product that's called Withdrawal, which is an IM every 4-week injection, and this product is a little bit of a better option. Oh, shoot. Is my recording going? Sorry, I just panicked for a second. It is. All safe. Thought I accidentally paused it. So anyway, you can give somebody an injection, then you don't have to worry about the whole oral compliance issue. They also use this drug a lot for alcohol dependence, which alcohol doesn't really have any mechanisms that we know of that work directly like an opioid, but there's some thought that via the reward system that alcohol may stimulate mu receptors via like releasing endogenous endorphins potentially. It's a bit of a questionable mechanism. We don't really know other than the fact that it does seem to prevent relapse for alcohol dependent patients in some cases. So you might see it used for that. Again, this is another drug that's kind of like naloxone. That's benign if you're opioid naive. And the major danger really with this is precipitating withdrawal because it is a longer lasting opioid. It's not really a concern for an alcoholic patient. You can't precipitate alcohol withdrawal with naloxone, or with naltrexone, excuse me. But for an opioid abuser, it would be something we'd want to just make sure that we're 100% clear that this is going to put somebody into withdrawal if we aren't careful with it.
Okay.
Yep.
Like naloxone, is there like a take home, like what you were saying about like
No, this isn't a take home thing. Yeah, it doesn't work all that quickly, and there isn't a fast acting injectable. The injectable is slow onset. It's a 4-week depot shot, so it takes a while for it to actually absorb into circulation once you've given it. And the PO is going to have PO onset, which isn't going to be helpful, especially if somebody can't protect their airway in an overdose situation. So yeah, it's not useful for that situation. So very different, very similar drugs really, but very different situations we use them in. All right, specific symptom antagonists. There's a drug called nalbuphine or Nubain, which is a partial agonist. It's not really an antagonist, even though it kind of works that way. And it's also a kappa agonist. And kappa receptors sort of have a different, if you remember back to the previous slides that showed the mu 1s and 2s and the kappa receptors, kappa can have like a dysphoric effect and work a bit of a functional antagonist role compared to a standard opioid. So what these drugs, what nalbuphine is used for is pain management maybe, but not really much anymore. We pretty much use it for opioid-induced itching. So I see this used a lot on OB, or people post-epidural if they're getting really itchy, which is unusual because we usually use fentanyl epidurals, which don't cause a lot of itching to begin with, but it is an option. It is like a standard order for those patients. So if you're getting an epidural, whether it's OB or another application for epidural pain management, you might see nalbuphine used, but otherwise it's a pretty uncommon drug. I'll mention methyl naltrexone too, which is Relistor. It's a very similar to naltrexone. It's a mu antagonist, but it's only peripherally acting. So the nice thing about this drug, it's really designed for opioid-induced constipation for people who are usually taking really high doses of opioids chronically. And it doesn't affect the pain management component of the opioid. So really it's only targeting the side effect because it's working peripherally. It's not getting into not crossing the blood-brain barrier, which is a godsend to people who have tried as many bowel preps as they can and still aren't getting a bowel movement. This drug actually works quite well for that. And it's actually, considering you don't have to use it all that often, basically people would only use it if they had a really significant episode of constipation, they might come in for it. It's only about $70 a dose. For a newer drug that's brand name only, it's actually not bad, and it's a pretty cost-effective option compared to some of the alternatives to like more bowel irrigation and stuff like that. So it's a nice, handy option. So if you work in chronic pain, it might be applicable. Otherwise, you'll never see it. All right, cough suppressants. So opioids work well to suppress coughs, kind of. There's no good clinical trials that support that any cough suppressant actually works all that well, even our drug codeine here. So codeine, I put under cough suppressants and not under our standard opioids because I don't really believe it's all that effective analgesic medication. Some people might argue with me on that, but I kind of think it's placebo. Metabolized to morphine, so you get about 1/10 of the potency of a dose of morphine with codeine, and the liver has to metabolize it into that morphine. It's used in combination with guafenicin, which is an expectorant drug that also doesn't really work all that well, and it's proven to be as effective as drinking water. Robitussin AC is the product there. So if you hear about that AC, that means with codeine. So if you're prescribing cough syrup and you want codeine, that's the one to do versus just Robitussin, which you could tell somebody just to buy OTC. And codeine with guafenicin is actually over the counter in some states. It's not controlled all that much. So it's like a C5 in some states. I believe Wisconsin for a while had it over the counter. I don't know if they still do or not, which is kind of crazy to think about, but that's the case. Because you can definitely overdose on this if you take enough of it. And then there's the other applications to codeine, which is Tylenol 3 or T3. This is something that I think people like to prescribe because it's kind of an opioid, but it's not really all that potent. So if you want to give somebody something that's not going to hopefully cause any addiction, but they're really bent on getting some sort of an opioid analgesic, you could try Tylenol 3. So it's going to be pretty weak compared to like a Norco or a Percocet, but it's the same concept. It's acetaminophen plus codeine. The 3 stands for, it's acetaminophen 300 milligrams and codeine 30 milligrams. And so that's what the 3 is. There's Tylenol 2 and 4s, and back when all these products were branded as Tylenol variants, they had it, but now it's all generic, and people only use the 3 product. I rarely ever see the other one. Dextromethorphan is the more common over-the-counter cough suppressant that you see in Robitussin and other, like it's in probably every cough and cold product that you see on the market. It's going to have dextromethorphan in it. It's not an opioid per se, but it's got the same structure of an opioid, and it works on some similar receptors in certain areas of the body. And Robitussin and Delsym are the brand names. The difference, Delsym has its specific controlled release version of it, which it says is better. Again, the question is, do these drugs really work? And there's not a lot of evidence that says they do. So there's been a couple pretty robust studies looking at all the cough suppressants that we have, and most of them have shown that there's no benefit in ever prescribing them. So when people always ask me, oh, what should I take for a cold? I'm like, nothing. You can't do anything. It's viral. It's going to go away. It's miserable, but you got to stuck it out. And you can take this if you want. Maybe it works. I don't know. Probably not any more effective than taking like something else that coats the throat. That's probably where you're getting most of your effect from in the upper respiratory tract. Yeah.
So obviously people will use or try to use protein.
Yes.
I feel like I've heard of people trying to use a lot of that before, right?
Yeah, it's called robo-tripping. That's my robot over here. You're probably wondering why that arm was on there. Yeah.
So does it actually have similar?
Yeah, it's kind of. It doesn't really have. It's from what I understand, it's hallucinogenic, and you have to drink quite a bit of it. But yeah, if you chug like a whole bottle, Delsum would be the more problematic product because it's controlled release, so you get a bit more of a kick off of that, I guess. But yeah, I don't know. From what I've heard, it's not. You don't really get the same respiratory depression, although I suppose you could. People tend to get more altered mental status and weird hallucinations on it. All right, anti-diarrheal drugs. So opioids work like to block up the guts, and we talked about opium a little bit. You can use tincture of opium for that, but these drugs are more commonly used. Lamodal is a prescription product. It's combined. It's a brand name product. So and it's combined these two drugs, diphenoxylate, which is the opioid component. Got to change my slide here. Which is the opioid component, and atropine. Atropine's added to this as an anticholinergic drug. Not to help with diarrhea, but to prevent people from abusing it. Because the theory is that if you inject yourself with diphenoxylate and atropine, the anticholinergic atropine is going to make you feel really gross. This is an oral product, so you'd have to grind it up and shoot it in. It's a weird diversion tactic. I don't understand it personally, but that's why they added it. It is a controlled substance. It's a C5, which is the lowest class, so low likelihood of abuse. People can take it, and if they don't get any response after 48 hours, they're probably not going to get any response from this. You can take it up to 4 times a day. It's an oral-only product, so it's probably one of the end-of-the-line anti-diarrheal medications until you get to something like Relistor or methyl naltrexone that we talked about for more of a severe opioid-induced constipation case. Loperamide or Imodium is over the counter, and this is again an opioid structure medication, but it doesn't absorb outside the GI tract, so it works in the GI tract alone. It should have similar efficacy to Lamodal theoretically, but because it doesn't have the abuse potential, we can do it over the counter. And I've never heard of anyone trying to abuse Lamodal. I just don't think it's possible. Or loperamide, excuse me. The dosing is you can do several doses in a day, up to 16 milligrams total, and you basically just take it after each loose stool until hopefully you get less loose stools, but depending on how significant your how significant what you've got going on is, it might be. So, all right. Yeah. Anyway, you can tell I'm a little sleep deprived. I'm sorry. What I'm talking about. All right. So that's, I think, it for medications. Let's look at a little bit of strategies for managing pain, and we're going to go through these, and then we're going to show you a calculation on the next set of slides. So chronic pain strategy, common with cancer patients, but you could probably find other diseases that have chronic pain components too, depending on what's involved. You really want to look at their daily pain medication use and figure out where to go from there. So if somebody is ramping up pain med use over time, the thing to assess is look at what they're on. So maybe you start somebody on just a short-acting medication as needed, and it turns out they're using it round the clock, and they're running out of refills, or they're running out before their time window should run out per, you maybe want them using 4 a day, and they're using way more than that. But they seem to be okay. They aren't abusing it. They're just in a lot of pain. That's your assessment as a clinician there. So if that's the case, you got to figure, well, okay, how much are they using in a day? And can I get that to a long-acting product? Is that appropriate at this time? Should I bump up the PRN dosing a little bit? I think that, I don't know, people have different plans for how they treat chronic pain. I think we tend to ignore using long-acting products more often than we should, in the sense that, if you give somebody a ton of Percocet or Norco, the acetaminophen combinations, and they're using them regularly, that puts them at risk potentially to overdose on acetaminophen. They aren't controlling their pain very well because they're constantly taking a short-acting product and trying to stay on top of that. So sometimes post-surgery, you'll see people prescribed like a low-dose oxycodone extended release, like 10 milligrams of OxyContin to take twice a day, which can help keep a baseline amount of opioid, and they give them maybe only a few days worth. It's definitely appropriate, and I think it's something that providers, especially in more primary care areas, don't utilize as much because they're afraid, for good reason, to prescribe a drug like oxycodone. But it's not that much oxycodone when you think about it. A Percocet tablet is 5 milligrams. The lowest strength of oxycodone extended release is 10. So if you're telling somebody to take 1 to 2 Percocet, you're already at 10 milligrams of oxycodone there. So it's really not that different. It's just going to last longer. Maybe will suppress their need for PRN short-acting quite as often. So let's say you're in a situation where somebody's using a lot, you want to switch them over. The general strategy, and I'm going to go through all the calculations, so just bear with me here. Especially I've got an example on the next lecture too. I'll show you all the math. But we want to convert to daily dose morphine equivalent. So I showed you the conversion tables. So whatever they're taking, you convert everything to morphine. So you want one common unit to work with, then you combine it all, and you're going to look at a long-acting agent to start a patient on. So your options really are fentanyl patches, morphine extended release tablets, or oxycodone extended release tablets. I mentioned there are a couple other ER tablets like a hydromorphone and a hydrocodone product. They really aren't used in common practice, so we'll ignore them for now. Patients should also have something for breakthrough pain. So you can't just prescribe somebody long-acting and call it good. You want something for that immediate release, and that should be about 10% of their total daily dose available. In practice, usually you end up prescribing like an as-needed 5 milligram oxycodone. It might end up being quite a bit more than 10%. But so that's just a rule of thumb, and it more applies to people who are like really chronic pain where they're on 100, 200 milligrams of oxycodone a day when you're looking at the 10% rule. Cross tolerance is something we consider too when switching patients. So let's say you have somebody getting IV hydromorphone in the hospital and you want to switch them to PO oxycodone at discharge. We consider cross tolerance. So when you convert all your hydromorphone daily dosing that they've been getting in the hospital to morphine equivalents, and then you convert that into oxycodone equivalents, you're going to decrease that oxycodone dose by about 25% to 50% of what you have. And that's because you get more effect once you switch the agent. The agent itself tends to have a bit of a novel effect in the body, allowing it to be a bit more efficacious right off the bat than the old agent was. So kind of an interesting phenomenon there. Again, I'll go through a calculation on that in a few slides here. Withdrawal. So if you've been treating somebody for pain management with opioids for a while, you're usually looking at withdrawal happening after about 3 weeks of daily use. So short-term procedure, a few tablets of Percocet here or there, not a big deal. Once you get to a few weeks of Percocet regular use, you're looking at trying to taper somebody off of it, or assessing, possible for tolerance, or if they're still in pain, it's not controlling it, or possible abuse at that point. Could be really any one of those, so you really have to be, if you're managing pain, I think that's a challenging point for a clinician, but it's something you'll encounter if you work with chronic pain patients or more long-term pain patients. So symptoms after typical agent, it's probably typical like onset after your last dose. So let's say you've taken 3 weeks of oxycodone and you're at the point where you might withdraw. So you stop taking it about 3 to 4 hours after that last dose. You're looking at craving, anxiety, fear of withdrawal. Nothing too crazy at this point, at least from a like physical symptoms. It's more mental, and the feeling of sort of impending doom almost, that you're out of your narcotic, you've been relying on it, what are you going to do? 8 to 14 hours, you're looking at restlessness, insomnia, yawning, some other things like GI type things might start happening. You might have some almost like cholinergic effects going on too. 1 to 3 days, you have tremors, muscle spasms, vomiting, diarrhea, and tachycardia. Withdrawal from opioids is extremely uncomfortable and anxiety-inducing. However, it's not fatal. And it's really only fatal if somebody were to go through this and be extremely like malnourished during it. So if they were already almost on death's door and they start going through opioid withdrawal, it might kill them. But for a relatively healthy person going into withdrawal, the odds of this killing them are slim to none. So yes, it's uncomfortable. Yes, it's problematic. And it'll create issues with people not wanting to go off their drug because it's so uncomfortable. It isn't going to kill them. Whereas several other things like alcohol withdrawal, benzodiazepine withdrawal can kill people if they stop them abruptly. You can use any opioid to substitute for treatment in the short term, but ultimately we talked about methadone and buprenorphine being the common drugs we use for chronic abuse patients who are going to be taking something for more of an addiction scenario. Opioid antagonists can be used to prevent people from going into to prevent people from relapsing once they've been treated through their withdrawal. So we talked about like long-term naltrexone use. Drugs like clonidine for blood pressure actually have been shown to work decently for opioid withdrawal. Benzodiazepines have some synergy too, which we'll talk about those during anxiety more so. And antiemetics can help with some of the side effects. Other side effect management, itching. Patients who take opioids will likely have some sort of an itching situation. So we use drugs that are mostly common antihistamines, diphenhydramine. Hydroxyzine is one, aka Withdrawal is the brand name of that. That's one that's really commonly used because it's a lot less sedating than Benadryl, and it's not quite as anticholinergic. It still gives good antihistamine response though. It isn't over the counter, however. It is a prescription product. Partial agonists, we talked about nalbuphine being used potentially in certain situations. Constipation. So we talked about some of the options here, but a bowel regimen is really required if you're on a chronic opioid therapy of any kind. So you can't neglect somebody's bowel when they're on opioids. If they're short-term as needed, you can kind of say, well, take some Senna or Docusate as needed. We'll talk about bowel meds during the GI lecture in more detail. But Senna is basically a stimulant laxative. Docusate's a stool softener, so they work synergistically together. You can't just give somebody a stool softener if they've been on opioids, because the problem is the gut's not moving. So if you soften the stool, you aren't solving any problems there. You have to get the gut moving. So a stimulant like Senna or a Miralax product tends to stimulate the gut a little bit better, can help flush things through. The Docusate's fine, but you need something usually a little bit more heavy duty than that. And then there's methyl naltrexone, which we already talked about. Addiction. So this is a question that comes up quite a bit, and it's of course a big problem facing society in general. What is the problem? And people are either prone to addiction or they're not, and the risk for developing an addiction to an opioid is about 3 to 5% of patients who take the drugs. It's actually relatively small. Kind of think of it like prescribing somebody an anticoagulant. Your risk for having a minor or major episode of bleeding is pretty similar. So it is a big deal. It's a lot of people who take these drugs. So it's a lot of risk out there. But it's not like everyone who takes opioids is going to get addicted to them. So let's get that clear, because I think there's some aspects of society that blame the healthcare system and providers for over-prescribing, and maybe that's true in some situations, but I think a lot of the time there are certain patients that just are prone to addictive behavior, and that's just the way that their brain is set up, and there's ways we can treat them for that, but it's not going to be everybody. It's going to be the small minority of patients you work with. So it's important, I think, to make patients aware of the risks of addiction. I think you should tell people straight up that, if you have an addictive, not necessarily addictive personality, it's probably a bad term to use, but if you have addiction history, or if you have family history of addiction, or maybe somebody is a recovering alcoholic and was addicted to alcohol for a long time, probably not a great patient to use an opioid on. They might be adamant not to use them too. They might understand that, but I think it's a good thing. Just like you'd tell a patient starting warfarin, you could bleed out on this medication. You should tell patients starting opioids, you could become addicted to this. And some patients, it does not take much to actually become addicted to. Challenges in prescribing and dispensing. Street value of these drugs is really high. And in fact, with all the regulations around prescribing opioids and all the crackdown on from the DEA on the prescriber and pharmacy end for over prescribing and also over dispensing these medications, it's been a lot harder for people who are addicted to get pills to satisfy that. So that's why the heroin boom we've been seeing has happened essentially. It's directly linked to the difficulty in getting drugs like oxycodone. It's very hard to get those. It used to be a lot easier. And they've shut down a lot of these prescribers who were making money by churning out a lot of this stuff, especially in like Florida and California had some huge areas with this. And I'll talk about that during drugs of abuse a little bit more. But the point is that when you're prescribing these drugs, there's a lot of regulations around it. And just be careful. There is a program called the Minnesota Prescription Monitoring, which I put on the link there if you want to look at it. If you ever prescribe opioids, which I guarantee you, if you're prescribing drugs, which all you guys probably will be, you'll probably prescribe an opioid at some point in your life, I would register with this system. You basically just put in a person's name and date of birth, and then it'll pull up their history. And there's several states that are enrolled. So we have one. If you go to this one, it's Minnesota specific, but you can search all the other states in the database too. You just have to do it individually, so it's not the most streamlined. But if you know somebody just was in Wisconsin for 3 weeks or months or whatever, and you're questioning that, you can pull up Wisconsin's database as well. So that's a great tool. If you ever have that question like, is this person duping me, or I just don't trust something about this, you can always double check and see what they've been filling. And I get that a lot from my ED providers, and most of the time it's not a problem. It comes up pretty clean. Every once in a while I get somebody and you see multiple pharmacies, multiple providers, lots of dispenses, and they weren't honest with the provider about when they last got their medication. So it is helpful in a lot of situations. So.
Chad,
yeah.
Do you have to be registered to access the database, or like?
You have to have a DEA number for a provider. So pharmacists we can also access it. So retail pharmacists can, if they think somebody has stole like a prescription pad and is writing themselves scripts or something like that, they can double check that too. So the vigilance is on both sides. So pharmacists have been dinged on this too by the DEA for over dispensing opioids. So my profession is very vigilant, and I think providers are getting really vigilant if they weren't already. I think Minnesota's been a pretty vigilant state, but there's definitely been some lacks in other areas of the country that have led to huge epidemics of this problem.
Is it all of their prescriptions, or is that
It's just controlled substances. So anything C2 through 5. So like if they fill Ambien, you can see that, but you won't be able to see like their blood pressure meds. Yeah, it's a good question. All right, some other analgesics just to run through. Tramadol is kind of an opioid. It's got some weak mu activity, but it also inhibits serotonin and norepinephrine. So we talked about drugs like that a little bit during the last segment and how they're used a lot in neuropathic pain. Tramadol is sort of a hybrid drug that is a bit in between, I would say. It doesn't have anything to do with like NSAIDs or Tylenol or anything, but it's sort of a step up from there, but not quite to a full opioid. So you see Tramadol used a lot, but for the longest time, Tramadol wasn't a controlled substance, which everyone who had any type of medical training whatsoever was saying that doesn't make any sense. And finally, they did control it within, I think, 2 years ago. It's controlled now, so it's a C3, I believe. And that took a while to get through, but it has helped. At least now we can regulate it a little bit better, and it pulls into the prescription monitoring program when they fill it. So you can see there were tons of people abusing Tramadol. It's just they could get away with it so much easier because it wasn't controlled for a long time. It's an oral-only product, regular extended release, usually dosed 3 times a day or so, and also use PRN. People don't usually take scheduled Tramadol. It's not like a chronic pain medication, although occasionally you see people who take like a dose every day. And, yeah, I won't go there yet. But newly changed to controlled substance, I said that, and you can use it in conjunction with other things too, so you can combine it with an NSAID or Tylenol. It is renally eliminated, so if somebody's kidney function is diminished beyond creatinine clearance of 30, you wouldn't want to use it in those patients. Lidocaine patches are a transdermal option for pain. Lidocaine we talked about really briefly, or I mentioned it really briefly during the derm lecture. But so it's going to decrease nerve impulses locally. It doesn't have it shouldn't have any systemic side effects, which is a nice option for people. Problem with the patch is it's local, so you aren't going to get a lot of systemic body relief with this. However, you can apply up to 3 at a time, and you can see they are actually quite large. So you could put them, over the small of the back. So somebody has lower back pain. It's a great option for a lot of people. Post-herpetic neuralgia, this is a really effective medication because it's all neuropathic related pain. And it's become a really successful product, and one that we see prescribed quite a bit, frankly. The other nice thing about these patches is you can see here, you can actually cut them. You don't ruin the patch delivery mechanism, so if you wanted to apply it to a weird area or a smaller area, you can do that easily. We do recommend only leaving it on for 12 hours because while the risk of systemic absorption is low, when you're using it chronically, lidocaine is an antiarrhythmic drug, and it can cause cardiovascular side effects. So when it's given as directed, 12 hours on, 12 hours off, it's fine. Just don't leave it on longer than that because you can end up accumulating it a little bit. All right, I'll come back to neuropathic pain a little bit during the neurology lecture, but I just want to touch on it really briefly. So multiple sources: diabetic neuropathy, postherpetic neuralgia, spinal cord injury, multiple sclerosis. There's some other ones. Those are probably the big ones, though. Often use non-traditional pain agents. So opioids are not first line, as they aren't first line really with any type of pain, with the exception of some really extreme cases. And the sensation is quite different. So it's usually pins and needles, burning or tingling versus standard nociceptive pain. First line treatment, again, we haven't talked about these yet, so we'll get to this stuff during neurology, but we use a lot of anti-epileptic drugs, and I listed a couple options there, or drugs that were developed as anti-epileptics, but really are terrible anti-epileptics, so they became good for this. Gabapentin's kind of a catch-all that they use for everything from anxiety to pain, and again, we'll get to that more. And then antidepressants, the serotonin norepinephrine reuptake inhibitors are the primary drugs here. Like you see, well, Cymbalta used to be brand name, it went generic recently, but you would see that advertised a lot as because it's a good antidepressant, but they found that they were making tons of money off this drug because people were prescribing it left and right for pain. It actually does work quite well for them. Okay. We'll end this show, and let's go through the first lecture here, or first part of this lecture. Just get this up quick. There we go. And talk about this chronic pain case. All right, so this case is going to walk you through what I'm going to expect you to do in an exam, which is convert between opioid doses. And again, if you do the problems that I posted online, and I'll post a key for those later this week, you will get hopefully all the points for it. I've rarely had anyone miss them, and they'll be almost identical with a few things changed to what I'm going to post online, or what I have posted online. So this is an example. We've got MM, 54-year-old male, significant pain, recent tumor resection. So he's currently getting 10 milligrams of IV hydromorphone per day via his continuous infusion. He's got patient-controlled analgesia and averaging about 20 milligrams of oral hydromorphone throughout the day as well. So they're trying to get him switched to more of an oral regimen, but he's still getting IV. He's getting quite a bit of pain. You want to convert to oxycodone for an all-oral outpatient regimen. So how do you do that? Oh, let's make this bigger. So step one, you got to get your conversion factors. Hydromorphone IV is 1.5 milligrams to 20 milligrams oxycodone PO, and hydromorphone PO is 7.5 to 20. So when you're converting, it's really basically simple unit cancellation. So what you have here is your IVH stands for IV hydromorphone. So you have 20 milligrams of oxycodone oral times 10 milligrams of IV hydromorphone over the conversion of 1.5. That's where I'm getting this. Hydromorphone IV 1.5 milligrams equals 20 milligrams oxycodone. They're currently using 10 milligrams of IV hydromorphone a day. So their IV hydromorphone oxycodone equivalence comes out to be 133. The second one is just the same thing, except I switched the conversion and I changed to the PO hydromorphone they're using, which is 20 per day. I mentioned in the other lecture that we convert to morphine equivalents first. That only really applies, I think, if you're converting multiple things. So if you're converting hydromorphone and they're maybe getting some oral oxycodone in hospital and you wanted them on like morphine or fentanyl patches or something like that, then you'd have to convert it all to morphine. I think it's easier just to use the direct conversion, but if it makes sense to you to convert everything to morphine and then convert it all over, that's fine. The point is you want it all in the same type of unit when you're done. So we're all doing oral oxycodone, so there we go. That's our total oxycodone equivalent of what they're using in hydromorphone in the hospital currently. Any questions on that? They're kind of looking at it right now. Mull it over and definitely let me know. All right, so we're going to add it up. So our total is 186 milligrams of oxycodone PO between what the patient is currently using IV and oral. And remember our cross tolerance. So we're switching to a different agent, so we want to decrease the total amount we're converting into. So we're going to multiply by 75 to 50%. That gives us our 25 to 50% decrease, which gives us a targeted range of 139 to 93 milligrams of oxycodone oral. So now so that's basically what I want you to be able to do. I will give you options that only figure into one of those, or will only fit into that range. So for example, I might give you a choice that says 60 milligrams of OxyContin BID. So 120 milligrams total daily fits into that range. I'd give you other options that are clearly outside the range. So I'm not going to expect you to be able to say, well, should I lean more towards the 93 or more towards the 139? It doesn't matter. It's pretty much considered to be the same.
Do you want us to remember to memorize the conversion?
Nope, I'll give you the conversion factors. And I'll give you a fentanyl patch conversion table as well.
check.
Yep.
The 0.75 to 0.5 is like, is that trying to reduce it 25% or 50%?
Or 50%. Yep.
Okay.
Yep. Exactly. So your final step is looking at this total daily dose that you're converting into chronic pain management, and then you want to give 10%. So 10% is only 12 milligrams of oxycodone per day, which isn't that much. So usually you would just do like a PRN as needed Percocet, and then or 5 milligrams regular oxycodone, something like that. That doesn't factor into your total daily. So this is just chronic. This is again on top of that, and this is the really diagnostic tool you can use for how effective your chronic pain or your round-the-clock pain regimen is, right? So if somebody's using a ton of extra Percocet, you probably need to up your round-the-clock oxycodone. If they aren't using any, you should decrease it, or if they're sedated, of course. But some people may be like, yeah, I'm taking the 60 oxycodone BID, I feel great, haven't used a single Percocet. Okay, it's time to drop that a little bit. I won't test you specifically on the maintenance dose. I'll give you like, I'll say that the maintenance dose is included. So really I'm just getting at this step 4 is what kind of answer you should be looking for in the exam.
So are we supposed to like memorize like what they're available in?
No, I'll tell you. Yeah, I'll give you like 60. I won't. Yeah, so this would be a real life situation you'd want to know, like because you can't prescribe 50 milligrams of oxycodone. It doesn't come in that. But I'll give you options on the exam. So yeah, as long as the math works out, you'll be fine. All right. And these are posted, and I'll have keys set up that walk through the math and everything too. So it should make sense once you go through it a bit more.
I have a real life question.
Yes.
So how can you do these for like 10 days or something? Like how long can you actually prescribe? How long is it?
What do you like? How much can you prescribe at one time?
Right. Yes.
Okay.
Yeah.
So for controlled 2s, you can usually only do 30 days at a time. There are some exceptions for some of the ADHD medications where you can do 90-day supplies, but you can't do that for any narcotics or any opioids. Yep, 30 days. So they have to come back every month to get a new prescription. Yep.
Chad, I have a question. This goes back to the previous PowerPoint.
Yeah.
In the emergency room, is there a typical case you prescribe Tramadol for?
Yeah, question for the recording is, for acute pain, would you prescribe Tramadol in any situation? That's a good question. I think it is one of those baby steps towards an opioid. So if somebody, maybe you've tried like giving them ibuprofen or giving them a shot of ketorolac in the emergency department and nothing's happening, maybe that's something you would consider giving them a short course of. I think people use it as it's kind of like takes the place of Tylenol 3 too. They're sort of in between going to like a full oxycodone or hydrocodone product where you get some of that opioid activity. I'd prefer Tramadol because I think it has a bit of a unique mechanism, but you definitely don't want to combine Tramadol with an opioid because it already has some of that effect to it. So it's a bit of a question of, how willing is your patient to take it? Do you really want them not to have a certain thing? Maybe they're really adamant that they don't want Norco or Percocet because they're afraid they're going to get addicted. You hear that a lot, believe it or not. So maybe Tramadol would be okay because you think they need more analgesic relief than just, an NSAID would provide. So it's definitely okay to prescribe it. It's just going to be, clinical scenarios are going to vary all over the place. But I wouldn't use it for really severe like post-op pain, but for like, something that they just need a little bit more than your standard NSAID, it's a nice option to have.
Should you avoid it for somebody you suspect is a drug seeker?
Yes. Mm-hmm. Yes, people will seek Tramadol. All right. Let's just do this follow-up. So what's this follow-up thing I have here? Assess use of PRN medication. So again, I already mentioned this. This is your litmus test for how well your regimen's working, and you can adjust it or not based on that. And then, of course, side effects too. Remember, we can only provide so much analgesic relief without killing somebody. So we can assess how sedated they're getting. We don't want them to be overly sedated. The idea is that these patients can generally function on a day-to-day basis. They shouldn't be in bed all day unless they're like recovering from some massive, nasty surgery, and they should be in bed or weight restriction or whatever. But for the most part, we want to keep them, especially like a chronic cancer patient, on their feet, maybe even able to go to work. Or operating a vehicle is a little tricky, and I wouldn't recommend that. But some people will get on these massive doses, and they'll be walking and talking. So it's interesting. But NSAIDs are always appropriate if the situation calls for it, as far as synergy. So it's always something that can be added. Unless they're contraindicated or something, you can always try that. And maxing Tylenol. There's some iffy data out there that says Tylenol synergy helps reduce overall opioid use, and that can be something that's tried. It's relatively benign. It's worth a shot. All right. So we'll talk about osteoarthritis when we come back from the break. Let's take 10 minutes. Come back at 40 after. Talk kind of some practical applications for how we might use them. So osteoarthritis, you usually have some sort of a joint affected. You could have one joint only. You could have multiple. Just depends on how somebody's put wear and tear in their body over time. Usually it's some sort of source, like somebody was a power lifter, so their knees and hips are gone or something like that you can attribute it to. Maybe idiopathic too, so you might have not really a known cause, but generally speaking, older people end up needing some sort of a treatment for osteoarthritis, depending on how they've lived their life. So we're going to try and relieve our joint pain. Inflammation and swelling are a big component, so that's going to key us into a major area of treatment here. Want to try and make sure they can function in their daily life normally. Preventing disease progression is not really possible using drugs alone. So usually you have to consider something non-pharmacologic, either exercise, weight loss, patient education for not putting extra stress on their joints, and ultimately you could be looking at surgery for some of these patients if they need a knee replacement or hip replacement. All right. So I break down your cartilage, it wears down, you end up with these bone spurs that grind on each other, and it causes pain and inflammatory response in the joint space. Early treatment, you're looking at mostly over-the-counter medications, and that's pretty much the mainstay of osteoarthritis. We kind of just stop the lecture after Tylenol and ibuprofen, but we'll talk about it in a little more detail on that. So Tylenol, non-inflammatory, it's got a bit of a question mark whether you should start it on everyone or not. I think if there's pretty severe inflammation that you can see, or can, if it looks like it's a pretty bad case or the patient's reporting a lot of pain, you might just want to go straight to the NSAIDs if they work, because Tylenol is not going to help with the inflammatory process. It might help people who have earlier osteoarthritis and they've not totally damaged their joints to a point where there's significant cartilage breakdown. Maybe it's only mild at this point. It can help. Patients might start as needed on their own. Generally speaking, if you have somebody with chronic OA pain, I'd go straight to 4 grams a day and just call it good. Go with your max dose, try it out, and see if it works that way. You can do PRN and kind of increase as needed, but that's going to be for patients who have really mild cases. If they want to try Tylenol, go big or go home with it, because it's not going to really work all that well for people in most cases, especially if they're taking wimpy doses of it. It's not going to work all that well. Tylenol does have the advantage that it should work fairly quickly, so you should get relief from Tylenol the first day you take it from the first dose. So it's not like you need to give it 2 weeks to see if it works. So if somebody doesn't get any response after taking high doses for maybe a couple of days, 1 or 2 days, I'd say is enough assessment to say, let's move on to something else. Statistically speaking, from studies, it has been slightly more effective than placebo for pain, but not not like crazy values. So it's mostly something that we're like, well, it works, but how effectively it works is a bit of a question mark. NSAIDs almost always beat it when put head to head. So, yeah.
Is it okay to take the 4 grams in one go?
No, sorry. So you want to space that out. Usually you do it every 6 hours. The question for the recording was, can you take 4 grams at once? And that's a no. Space it every 6 hours, so 1 gram every 6. So.
No 4 grams.
No gram. No, do not do that. Please don't. Sorry.
People on these for years.
Yeah, you can be on it chronically. Yeah, especially if you keep the dose to a minimum. If somebody goes into liver failure or something, you might want to cut back on it. But otherwise, it's fine. Yep. All right, so if acetaminophen fails, or you're like, this is really inflammatory OA, we need to get some bigger guns out, you want to pull out your NSAIDs. And you want to schedule these as well, specifically because you need to suppress inflammation round the clock, or you aren't really going to help the patient all that much. So these drugs, now where Tylenol, you should get, well, that was interesting. You should get some analgesic relief from Tylenol right away if it's going to work from you. With an NSAID, you're looking at more that anti-inflammatory effect. Now, it's going to provide analgesic relief too, which is great. But over time, you should get some anti-inflammatory effects to build up, and you should see the results of those. So usually you're looking at more weeks to verify whether the therapy is going to be all that effective. This kind of goes back to, as far as dosing goes, I didn't put any dose examples up here. But when we were talking about like the ceiling effect of NSAIDs and the inflammatory versus analgesic ceiling, usually with this, you tend to go with higher doses because you're targeting more that inflammatory response versus just purely analgesic response. Of course, we talked about risks a lot with these, so I'm not going to rehash those, but use caution, especially with elderly patients, heart disease patients, kidney disease patients, etc. There's a specific prostaglandin, E2, that's thought to contribute mostly to the OA symptoms, so that's a suppression effect that NSAIDs are preventing the release and upregulation of production of that. Prostaglandins in that one specifically, which is thought to be one of the primary mechanisms. All right, so is there a choice of NSAID? We talked about that there's no real benefit to one or the other and no convincing evidence that one works better than the other. And that's true for this too. I think naproxen is probably your best bet to start with. The one reason I like it over ibuprofen is it's more convenient to take. You get a more sustained response with it. Ibuprofen's fine. If somebody wants to take that, no problem. And again, you'll run into people who say one works and the other doesn't, etc. But make sure the dose is right too. So they might be not taking enough naproxen. Naproxen, just like ibuprofen, if you read the over-the-counter label on the bottle, it tells you to take 1 to 2 tablets. In actuality, you can take quite a bit more of that. Just make sure you understand the dosing cutoffs for that. There's some prescription naproxen products that are higher dose, and those might be more convenient for the patient to take if they want to take something that's not taking a handful of pills a day. Ibuprofen's the same way too. So you start with one of these, and I'd say if one doesn't work, try the other one. And if that's not going to work for you, then try another NSAID. So then you might move to some of the more complicated ones, like the COX-2 selectives, or maybe meloxicam, which is a once-a-day dose. Try some of those prescription ones. At what point would you say, I'm done with NSAIDs, I want to move on with my life? That's a good question. You could just keep, there's several out there, so keep going until you call it good. Or I would say once you've tried probably 2 or 3, that's a good time to say this isn't really being all that effective. Just make sure the patient's been adherent with it, taking it consistently, not intermittently, and also taking an appropriate dose before you give it, call it quits for good. So topical products are something you can use synergistically with any of the oral products we mentioned. Remember, there's that diclofenac gel or patch. It gives you a little bit of systemic absorption, but a lot less. I wouldn't necessarily recommend combining this with an oral NSAID because there is that systemic risk, so probably not. But for those patients with elderly or who are elderly or with renal dysfunction, CV risk patients, this might be a good option, especially if only like one joint is affected. It's like their left knee, they can easily apply it directly to the site. It actually might work even better than an oral medication in some cases. I don't think I talked about capsaicin yet. Capsaicin is a product that is synthesized from the active component of hot chili peppers, and its mechanism rapidly depletes substance P, which is a pain mediator in the body. And so it depletes the available amount of that you have in your body. So you get a diminished pain signal transmission. Does it burn when you put it on? Yes, a little bit. So don't touch anywhere sensitive when you're using it, like eyes or other sensitive areas, you can probably imagine. So that's a good option for people. People actually get decent relief from this. Again, just tell people to be careful with what they're putting on, what they're rubbing up against, because it could end up, like if they rub up against like a kid with like a baby with sensitive skin, I could imagine that being really problematic. So just don't let grandpa apply a bunch of capsaicin and then grab a small baby. It's probably not a great idea. Yeah.
Do any of the other like prescription NSAIDs like really get prescribed, like indomethacin? Like, does that
Indomethacin
have any benefit over like
no.
someone who's ibuprofen?
Nope. There's been studies that say it's as effective as ibuprofen. Yeah. There's no NSAID study to my knowledge that says one NSAID is more effective than another NSAID in any case.
All right. Thank you.
Lidocaine patches too. We just talked about those. I put this topical product slide up here, and I think I've already said this, but I'll say it again because we're saying there is lots of limits to treating pain, and topical products I think are overlooked because of their adherence issues, inconvenience potentially, but they can really be nice for some patients. And specifically the capsaicin and the lidocaine are new mechanisms that you could give oral NSAIDs and give these at the same time. And the diclofenac gel, of course, has its own role too. So don't forget about these when you're treating people's pain. They're nice choices for a lot of patients out there. Intra-articular steroid injections is kind of the last step you'd go for OA before you went to surgery. I mean, usually once you're at this point, you're kind of bridging to surgery anyway. So what you're thinking about, or patients you're thinking about giving these to, would be somebody who has 1 or 2 joints affected. More than that, you don't want to be injecting somebody with like every joint in their body with steroids. It's not going to be easy to do. You're going to risk systemic side effects significantly, and it's just not sustainable. So like one or two, a knee or a hip or something. Hip probably not. More knee. I don't know if they do hips. Maybe they do. bigger doses probably. But moderate or severe pain, and really these patients who would qualify for this aren't getting relief from your oral drugs like NSAIDs or acetaminophen, or the NSAID is contraindicated. So your corticosteroid injections, you get max benefits about 2 weeks after the injection, and they wane. Usually people do like a 3-month interval, so they'll wait for 3 months. That's about the window of efficacy you might get, and that's going to vary patient to patient. And triamcinolone and methylprednisolone are the drugs of choice here. Triamcinolone comes as a product called Kenalog. Methylprednisolone comes as a product called Depo-Medrol. And they're both these kind of oily, viscous products that are designed to go into the interarticular space and stay in there so they don't get elsewhere in the body. You do not want to give one of these products IV. You probably would kill somebody. So just make sure you're ordering the right product. Not funny, but you never know. So anyway, larger joints, larger doses. The dosing's a bit, I always say steroid dosing is not really a science. It's kind of like, well, let's give somebody a bunch of steroids and see what happens. And this is the same case. You're going to pretty much want enough product to get into the joint space, so larger joint, just use a bit bigger of a dose. And there's plenty of dosing guidelines out there, so I'm not going to go into that, but you may need a lot for different joints depending on what you're treating. Glucosamine chondroitin, we haven't talked about our supplements yet, but it's good a time as any to dive into that a little bit. So this is an OTC product that's kind of controversial, like essentially every single over-the-counter supplement. There's not compelling evidence to use this product is pretty much the bottom line, but it does have few risks associated with it. One of the problems I see with these cosamine products, they tend to be kind of expensive, so if somebody's, I don't know, resource limited, you might not want to recommend this to them. If they have money and they want to try it, it's not going to really harm them, so it's worth a shot. There are some really not great examples of studies out there that show that there's some evidence that this may actually have mild preventative benefits. So interestingly enough, what we've been talking about here is treating pain, not necessarily preventing it from occurring. And so the concept of glucosamine chondroitin is it actually prevents cartilage degradation and stimulates proteoglycans, which help to build up cartilage. Now, in clinical evidence, we haven't actually seen robust studies to say that that actually happens. There is some evidence maybe leaning in that direction, though. So, it's a risk benefit. There's not really any risk. There might be a benefit, but there is a cost associated with that potential benefit. Yes?
So when would you actually prescribe this?
Anyone who wants to try it, really. I would say if somebody's having early OA, you might recommend trying it, especially if they're open or if they're more into alternative medicine. Maybe it's a recommendation you make if they don't want to take like acetaminophen or an NSAID regularly. Other patients, once they've progressed in their disease, I would probably not recommend it at all. Like if they're at a point where they're getting steroid injections, not going to help them.
Is this for the kidneys? Or
from what I know, I don't think it has any contraindications to its use, but I'm not 100% sure on that. Yeah, I don't think it's renally eliminated or has a problem with that. All right. So treatment for OA, acetaminophen is your first line. Exercise, weight loss. Exercise can be really tricky, especially if the patient's got a major joint affected. So that's going to be questionable whether you're going to be able to do enough load-bearing exercise to really work the patient. Swimming could be a good option for patients if you want to get them some exercise. It's not impacting the joint. So if you're failing APAP or your initial inflammatory response is high enough where you might think APAP's not a good option, your ibuprofen, naproxen would be the next step. Other NSAIDs probably after that. Steroid injections. PT could be incorporated really anywhere in here. I just kind of threw it in there because I didn't want to forget about our PT friends. But that's definitely an option. And failed multiple NSAIDs or serious adverse reactions, joint replacement. And then ultimately I threw opioids in the corner. If somebody's pain is so bad that they need opioids, they might need them. But that should really be only in a situation where they're really close to surgery. I wouldn't think of that as a long-term solution. Again, I would kind of put that in the bucket of steroid injections where it's a bit of a bridge to a joint replacement at that point.
What if somebody isn't a surgery candidate? Then would you just bump back to the opioids?
Yeah, you might have to get there at some point if it's really bad and if they're not a candidate. Like if they some people need to lose a lot of weight. It's just not going to happen for a knee replacement. Yeah, sometimes you might end up with tricky situations like that. I'd still be pretty cautious. I'd probably hit that joint with anything topical you can, and then max out your NSAID dosing as you can. You can do NSAIDs and Tylenol too, so try everything before you go there. But yeah, you might need to in some cases.
Why do you do the acetaminophen before the NSAIDs if the NSAIDs are more effective?
Because acetaminophen is pretty benign. It doesn't have as many side effects. Doesn't have GI bleeding risk. Doesn't have kidney damage issues. So your problems with acetaminophen really stem from overdosing on it. That's about it. So it's worth a shot, and it works quickly. You're going to know really fast whether or not it's a viable option or not for patients. All right. Moving on to rheumatoid arthritis. So rheumatoid arthritis is quite a bit different than OA. So we're switching gears here from pain management for kind of a standard, what we might think of as standard, like old aging pain, to something that's an inflammatory disease, autoimmune disease. So rheumatoid arthritis, more severe pain, immune response to the body. People of any age can be affected, where people with osteo, usually it's older patients. Symptoms throughout the entire body. Usually osteoarthritis is limited to the specific joints it affects. Usually women more than men for rheumatoid arthritis, and osteo is similar in both genders. So our treatment focus is on control of inflammation within the joint synovial space and prevention of injury over time. Pathophysiology is different, and the treatment strategy is completely different from osteoarthritis. However, that doesn't mean you can't use some of the same pain-relieving strategies you would in osteoarthritis. You can give these patients NSAIDs and acetaminophen. It's just not our endgame treatment strategy. And that's going to be drugs called DMARDs, which are disease-modifying anti-rheumatic drugs. So all the drugs we talk about, the next several slides, are DMARDs. And this is usually going to be specialist driven. So if you work with like a rheumatology clinic or a clinic that specializes in rheumatology, you'll see these types of patients. So our treatment principles here: identify and refer. So differentiating between rheumatoid and osteo, of course, is important. I'll leave that up to our clinical experts in the room, not myself. Achieve tight control of the disease. Frequent monitoring is required. And you want to escalate and use prompt use of your disease-modifying agents. You don't want to try and bridge somebody with an NSAID and say, oh, let's just see if ibuprofen works for this patient. They truly have rheumatoid arthritis. You want to get them either you are the rheumatology provider and you're going to treat them appropriately, or you're going to get them to one that can. So that's really the moral of the story here. So initial DMARD options. These two drugs are both oral, and they aren't really as commonly used, and we'll get to why that is in a second. But they are pretty well tolerated, and for the most part, fairly benign when it comes to side effects. Hydroxychloroquine, or Plaquenil, is this old anti-malarial agent that inhibits neutrophil and eosinophil chemotaxis, which can help with the inflammatory process that's going on. And it also impairs some antigen-antibody reactions, which may or may not be responsible for RA. Autoimmune diseases, I should just say this, are tricky to treat, and so there's no exception here. And as far as the mechanism of action of what is actually happening in the body, there's a lot of things at play. So it's very difficult without suppressing the immune system on a broader sense really to focus on that. We'll get to some of the drugs that do that in a second here. Sulfasalazine is a drug we'll come back to with ulcerative colitis and Crohn's disease. Very similar treatment with those as well. So really, to back up a little bit, when we're talking about psoriasis, rheumatoid arthritis, and Crohn's disease, very similar diseases. They're all autoimmune. They're all treated very similar to with a lot of the same drugs. You can kind of put those all in a bucket if you want to. Sulfasalazine is a ulcerative colitis medication that has supposedly a local anti-inflammatory effect in the GI tract. So how it works in rheumatoid arthritis is unknown, but there is some clinical evidence to support its use. However, people who don't have an inflammatory GI disorder to start with might end up with GI side effects from this, so it might not be the best option. You can combine NSAIDs with these medications. You can give steroids. So if somebody's having an RA flare, you could give like an oral burst of systemic steroids. That's fine. And for any DMARD on this slide, you're going to look at 12 to 24 weeks. So quite a bit of time before you're going to consider it a failure or a success. All right, moving on to methotrexate, which is probably the more common first-line agent. Well, those ones we just talked about, technically there's less side effects. They're more easily tolerated. This is really more commonly used as a more potent first-line agent. So this is an anti-metabolite, and it's a broad immune suppressive agent. We don't really understand exactly why it works in rheumatoid arthritis, other than that it has some immune modulating properties to it. So it's technically reserved for more moderate disease, but it's got a faster onset and comparable greater efficacy to the agents we just talked about. You can combine it with other DMARDs, so triple therapy. We'll get to that in a second here on some of the studies and the newer agents that have been combining methotrexate. Depending on the practice setting, the most common line, first line for DMARD and This is a once weekly medication, so usually it's oral once weekly. You can also give it IM as well, so small IM injection once a week. And these doses are much smaller. We talked about methotrexate a little bit with chemotherapy regimens. A lot smaller doses used for this than compared to some of the chemo regimens where we just hammer people with methotrexate. Myelosuppression, liver dysfunction, and GI issues, pulmonary fibrosis, less so much, but those three I mentioned first are probably the biggest ones here to worry about. So monitoring is important with this, CBCs and LFTs, etc. You need to keep up on fairly regularly until the patient's stable on the regimen. Discontinuation rates are quite high, mostly due to these GI issues. People get diarrhea and nausea. They just don't feel all that great, and they're pretty high percentages, 20 after 2 years, 35% after 5 years of treatment. So definitely not what we want to see when we're looking at a drug that's kind of first line for this disease. Teratogenic, so we talked about rheumatoid arthritis affecting women and younger patients, which obviously is problematic. So that wipes out a lot of patients there. And all patients should be on folic acid. So this is an folate antimetabolite, so it does alter the metabolism of how your body uses folic acid. The way we overcome that is we give more folic acid to help shunt that folic acid through different pathways and supply that as a separate supplement. It does seem to work fairly well, but it is a requirement for patients to be on a fairly high dose of folic acid daily while they're on methotrexate. Leflunomide, or Araba, is a very similar methotrexate alternative. It's another base pair modulator, so it's an anti-immune modulator, and it's useful mostly as an alternative to methotrexate for people who, for whatever reason, don't want to take methotrexate. Maybe it's more expensive, there's insurance issues, maybe there's a number of things you could consider, but the bottom line is the side effects and discontinuation rates are pretty much the same. It's also teratogenic. So kind of think of methotrexate and leflunomide being really interchangeable, so I'm not going to really spend much more time on this. All right, so I skipped over these during psoriasis, so now we're back to the tumor necrosis factor alpha inhibitors. So these are expensive biologic agents that are getting more and more commonplace for the treatment of autoimmune diseases because they work extremely well. They're highly effective monotherapies. They do require injections, so they aren't oral. Like with any, when I say biologic, just a reminder, what I'm talking about are large protein molecules that are given in injectable form. So things that end in MAB, like monoclonal antibodies, are going to be our treatments here. So these are always going to be second line to methotrexate unless the cost decreases. These are expensive. Like with any biologic thing, cost is they come at a premium price. But I think as we see medicine shift a little bit and the results maybe come back favoring these agents, maybe they say that, well, if you start somebody on these agents, they have less long-term side effects and complications to the disease, end up saving money over time. Now, that's definitely possible. So we aren't quite there yet, but I wouldn't be surprised if methotrexate goes away completely and we're only using Enbrel and Humira for these patients.
Why are they so expensive?
Biologic it's expensive to make biologic products, and you can never, even if you make to give you a brief overview, biologic products forever were not able to be generically made because there's a large argument that says that you can't make a generic biologic because of the processing techniques behind it. So you have to usually make a cell line that's going, usually like a bacterial cell line, or you make it through PCR or something where you're synthesizing some sort of amino acid sequence. And to do that on a large scale and to make it pharmaceutically preparable is really difficult to do from a cost perspective. So that's why they're so expensive. There are some what they've called our biologic equivalents, which is, I believe, something that went through for the Affordable Care Act allowing this to happen. So this is allowing drug companies that are kind of making generic biologics. The problem is with the generic biologic is you're only really reducing the cost a very small amount. So like, let's say you have a generic oral medication, the cost eventually will probably be like $1 maybe, and it used to be like $10 a pill. These drugs might be $100 a dose. You might get them down to $80 a dose. So the cost reduction isn't there just because the process is so expensive to do. A lot of drug companies don't want to get into it because it's expensive to make them. So that's where we're at. I do think we talked about the filgrastim products that stimulate white cell production during chemotherapy really briefly. There is a biologic equivalent of that product. And I think there's one for Humira coming on the market. It's either Enbrel or Humira that's either in approval processes right now. But the problem is, too, is they kind of have to go through a whole other approval process that's not like a standard generic drug. Generic drug manufacturers don't have to prove efficacy of their product because it's already proven effective. These companies, I believe, they do have to go through like basically a full new drug application for it. So it's a lot more complicated to do it. But anyway, we have two drugs here that are the most common ones, and then some newer agents too. So Enbrel and Humira, or etanercept and adalimumab, are the old standards. These are some of the biggest money makers on the current market right now. You see them advertised a ton on TV. And the reason is because these diseases affect a lot of people, and autoimmune diseases are relatively common, and we see them being quite effective for them. So they're a good option for a lot of patients. We'll talk about these more on the next slide too, so we aren't done with them yet. But some newer agents too. There's some newer tumor necrosis factor alpha inhibitors, Cimzia and Simponi. Essentially, they're Me Too drugs. They both were used and trialed in a combination with methotrexate. So technically, they aren't approved for monotherapy, whereas these two drugs are. So that's the big difference. So maybe you'd think of it more as a second line. But these drugs have also been studied with combination methotrexate therapy. So for more advanced disease, you can maybe consider that dual combination of methotrexate plus any of these TNF alpha inhibitors would be fine.
Are you changing the dose for like psoriasis or like the different?
There is,
for a lot of
yeah, there is slightly different dosing and regimen intervals. So some of them will do more frequent injections, some less frequent, some different dosing, but it's fairly standard across them. But yeah, you do have to be careful when dosing them. Yep.
Does your first line of treatment change depending on like the stage and severity of it?
Yeah, that's a great question. I think if it's severe to start with, you'd probably ideally in a perfect world want to go right to one of these drugs. However, the cost is going to be prohibitive for a lot of patients. So if it's severe, you're either going to look at methotrexate or a TNF alpha inhibitor. You're probably going to skip that first slide of stuff altogether. But yeah, it's a good question. Yeah, until these come down in cost, if they ever do. Yeah, technology will get better, I think, eventually. We might be able to prepare them in a more cost-effective way, but we haven't gotten there yet. All right, so a little bit more about these drugs. Enbrel or etanercept is very well tolerated, so is adalimumab. You think of these drugs as being a bit of a broad immune suppressive agent, but for the most part, they don't really cause a lot of risk for infection. The real tricky part is making sure people don't have some sort of underlying disease that's going to be brought from a latent stage to an active stage. So tuberculosis and hepatitis being the two big ones, and that's going to be the major contraindications to these. These drugs shouldn't really put the general person at higher risk for like a common cold. However, they can. So it's a bit of a give and take. Most people tolerate them quite well. The problem with injecting biologic proteins into your body is they're highly antigenic compared to a standard drug. And while the reaction rate's still quite low, comparatively speaking, you still have that risk to consider. So one of the differences between Humira and Enbrel is that less people will react like in an anaphylactic way to the initial injection from adalimumab. They're both quite expensive. Once weekly dosing for etanercept, $700 per dose. Every other week, $1,500 per dose. They're about the same total price when you're looking at it. There's another TNF inhibitor called infliximab or Remicade that's used in combination with methotrexate. At least that's how it was studied. It's an IV-only product, so this wouldn't be like a take-home injection like Enbrel or Humira would, but it could be an IV product. It's more commonly approved for Crohn's disease, but it is have some off-label use for rheumatoid arthritis. All right, so these drugs are also biologic injectables. However, they aren't TNF inhibitors. So you have abatacept or Orencia, which inhibits T-cell activation. So T-cells are found in the synovium around RA patients. So the idea you don't activate as many, you get less inflammatory response. It's got an IV loading dose plus a monthly infusion, or you can do a sub-Q weekly. So it has both options available. Headaches and respiratory infections are common side effects with it, but again, common relatively speaking. A bit more common than the TNF agents. Tocilizumab, I think I said that right, is Actemra, and it's an antagonist of IL-6. So interleukin-6 is a specific inflammatory mediator that's produced by is produced by inflammatory stimuli and mediates immune response. It's IV or sub-Q, and you can see every week or every other week. There's multiple dosing patterns depending on what you're treating with it. Adverse effects, it does increase cholesterol, interestingly enough, and it does have some effects in the liver, so it might raise your LFTs a little bit. Maybe some neutropenia in some patients, but a little bit rarer there. Just some other options. And then we have rituximab or Rituxan. We mentioned this during transplant a little bit. So this is an antibody against CD20. This is a more last line type of a thing. So I'm not really going to spend much more time on that because we've already talked about it just a little bit. It's an IV-only infusion. And it's, again, this is your big gun. So if nothing else is working, you might try this, but it'd be pretty rare, I think. Then there's a newer drug called tofacitinib or Xeljanz, which is not a biologic product. It's an oral product. You remember Gleevec, that article I posted, and I talked about that as kind of an example of tyrosine kinase inhibitors, which are super expensive oral drugs. They're kind of the hot drug on the market when it comes to immune modulating right now. There's tons of them. This specific one was developed for rheumatoid arthritis, and it's a nice option other than its cost because it's oral. You can combine it with, you can't combine it with other biologics, so it's a monotherapy, but it does have pretty decent data associated with its use. So there's, again, more options for these patients, I think, is a good thing. Problem is $2,800 for 38-day supply. I mean, it's not a biologic product, and it's priced like one. So it's kind of interesting how these drug companies choose to do this. All right, so our treatment strategy, overall initial treatment, you're going to consider any of these, and really with the focus probably being on targeting methotrexate as initial therapy, and then seeing if maybe the patient has a contraindication for it. If they're a young woman who's going to have a family soon, definitely not an option. So if it's mild disease, you could go maybe back step to like a hydroxychloroquine. If it's more advanced disease and they don't qualify for methotrexate, I'd go straight to the TNF alpha. And then ultimately, it's up to you and the patient to figure out something with insurance. A lot of times insurances might have some benefit type things where they might give you a discount on it when you first start taking it. I think because these drugs are becoming so much more popular, a lot of insurances are paying for them. They just might require you to do some paperwork on your end to prove that they actually, yes, do need this drug. Still not responding, you can combine your TNF inhibitors with methotrexate. You can try those other biologic agents. You can try Xeljanz. You can try switching the TNF to a different one. So maybe go from Humira to Enbrel. That might work for some patients. Consider rituximab in really severe cases. There's a number of different combos you can try. Yeah.
You ever combine biologics?
Not to my knowledge. Yeah. The only combination studies I've seen are done with combining the TNFs and methotrexate. I haven't seen biologic and biologic. All right, any questions on RA before I move on to gout? Gout, I just want to touch a base on really quickly because it's kind of an inflammatory rheumatoid disease. So gout involves accumulation of uric acid in a joint, most likely the big toe in patients. It tends to be just gravity accumulating there. I've got the actor from Game of Thrones who plays Robert Baratheon here for Song of Ice and Fire, Game of Thrones nerds. This is my archetypal gout patient, even though he didn't have gout. And I know there's another character in the book that did have gout, but we'll leave the nerd fandom down, turn it down a notch here, just focus on this guy. So if you've seen the first season, you might know who this guy is. He drinks a lot, eats a lot, and doesn't really move around a lot. It's kind of the disease of kings, which was what gout was associated with. And it still affects people today, and it's going to affect that general patient population. Not to say those are the only people that get gout. Other people can too. Usually it's lack of mobility, obesity, and diet, which are associated with it, and alcohol use. All right, so how do we treat this? 3 different ways primarily. There's some biologic agents, which we'll talk about too, but let's focus on the first 3 bullet points. So NSAIDs, colchicine, and glucocorticoids. And you're really going to treat basically the same way depending. It doesn't really matter what agent you do. The treatment strategy is pretty much the same. So start as soon as the attack is coming on, continue for the duration. Usually about 2 to 3 days after complete symptom resolution, you can stop the drug. Chronic medications are taken to suppress gout attacks, and we'll talk about those just on a slide here in a second, but they don't help during an attack. So it's not like you bump up your allopurinol, which we'll cover here in a second. Okay, so NSAIDs, naproxen and indomethacin are the 2 drugs that have been studied most heavily in gout. However, any NSAID is probably okay. This is where you get to is one NSAID better than the other? And while I say that none have really been proven to be better than the other, some just get used in certain areas because they have been studied in that area, not necessarily because they're any better than the other one. So I get indomethacin prescribed a lot by our prescribers in the ER just because, again, there's data associated with it. But any NSAID should be fine. Ibuprofen should be fine. Naproxen's great because, again, it's twice a day. You don't have to take it as frequently. Indomethacin's like a 3 times a day medication. Okay, so initiate within 48 hours of the attack. Of course, NSAID contraindications apply. Another second option, glucocorticoids, PO, IV, intra-articular. You could inject glucocorticoids directly into the joint. That can help. in some patients. If they're unable to tolerate NSAIDs, so an elderly patient, GI bleeding risk history, CV disease, you would consider this as maybe a first-line option. So NSAIDs usually are a first-line therapy. Glucocorticoids reserved as a second line. One thing to remember about glucocorticoids are their side effect profile, which isn't great, and especially during a gout flare, the dosing's a little bit high, so they could end up with some mood changes. Diabetic patients are at risk for hyperglycemia episodes. So those are the two most acute things I would be concerned about with treating patients, especially with this patient population. Generally, obesity is associated with higher risk for diabetes, so even if somebody isn't diabetic, I've seen lots of patients who take glucocorticoid courses, even relatively healthy people get really high spikes in blood sugar just for that reason alone that they're on the drug. So just be mindful of that. You might have them monitor their glucose if you think it's relevant. Colchicine is kind of your second line if NSAIDs are contraindicated, and there's some debate among providers that I've talked to whether they like colchicine or steroids better. I think most people tend to like steroids better. People are a little bit afraid of colchicine. It's got an interesting mechanism of action. It arrests microtubule assembly and inhibits some cellular functions and neutrophil-related inflammation. You start off with a really high dose of colchicine and then taper it off. Sometimes you can use it daily for prophylaxis too. But there aren't any trials comparing efficacy of NSAIDs to colchicine, so we don't technically know based on the data if one's better than the other. It's all anecdotal. Adverse effects are the big reason why people don't like this. Diarrhea and abdominal cramping. GI side effects are pretty strong with these drugs, so it tends to lean people towards the other two treatments I just talked about. Strong CYP3A4 inhibitors with renal and hepatic failure is a contraindication, so that rules out some patients too. And these drugs are CYP3A4 metabolized, so if you inhibit them, you're going to get increases of toxic side effects, which can cause some of these side effects to inhibit some of the processes, including mitosis and protein assembly, which can have some nasty toxic effects within other areas of the body. So again, people don't like colchicine for some of these reasons. Most people will be like, I don't know what a CYP3A4 inhibitor is. I don't have time to look through the 30 drug medication list, which is fair. I'm just going to prescribe an NSAID. That's perfectly acceptable. Okay, I don't want to scare you too much from colchicine. I feel like that's kind of scary. It's fine to use for the most part, but there are people that really don't like it out there that I've worked with. So.